Guillain-Barré syndrome, also known as GBS, is a rare neurological autoimmune disorder that affects the body's peripheral nervous system. The syndrome destroys a nerve's myelin sheath and exposes the nerve fibre, causing a range of neurological symptoms. In approximately 2/3 of patients affected by GBS, recent history of a respiratory infection or gastroenteritis was notable before the onset of GBS. Interestingly, neuroscientists at the University College of London have found no significant association between COVID-19 and GBS. There are a few theories over the cause and development of GBS. However, the exact pathogenesis of the syndrome is still unknown. Some pathogens being linked to causing GBS include C. jejuni, influenza A virus, hepatitis E virus, Epstein-Barr virus, and cytomegalovirus. However, the development of GBS from these pathogens are sporadic and follow no distinct pattern. It is believed that the development of GBS is most commonly due to antibodies that have cross-reacted with specific cell membranes of a nerve. This process will generally only occur in patients susceptible to illnesses, which may explain why only some respiratory or gut infections develop to a more sinister illness. A patient affected by GBS will initially present with finger dysesthesias and proximal muscle weakness of the lower body, progressing over hours or days, spreading to the upper body and eventually to the muscles of respiration. GBS can be fatal when the syndrome eventuates to paralysis or interferes with breathing, blood pressure, or heart rate. The syndrome's presentation, however, differs greatly between patients with respect to the extent and presence of cranial nerve deficits, weakness, pain, sensory deficits, autonomic dysfunction, and the course of the disease. There is currently no cure for GBS. However, plasmapheresis and immunoglobulin therapy have been known to speed recovery and reduce the severity of symptoms in patients. GBS is a rare disorder affecting between 2 to 8 people in every 100,000 in Australia. When considering the prevalence of acute respiratory infections alone, Australia reported 68.9 million cases in 1 year. This puts into perspective how rare these infections can develop into GBS. Age is not a diagnosing factor in GBS as it can affect anyone. However, it is most common in those aged 30 to 50 years. It is important to note that the most common initial complaint from the patient is difficulty walking or climbing stairs from weak muscles, as well as tingling or vibrations in their fingers or toes that have been getting worse over hours or days. It is essential to identify this diagnosis early, as the nerves of the autonomic nervous system are likely to be affected as the syndrome progresses. An important factor to recognise is whether the weakness or dysesthesias are beginning to spread further up the legs or arms, or if paralysis has developed. Failure to recognise these factors may result in paralysis that can lead to death. Symptoms of muscle weakness, dysesthesias, and pain are very broad symptoms that could account for a number of disorders. Differential diagnoses for a chiropractor to consider would include acute myelopathy or radiculopathy, spinal cord compression or spinal cord syndromes, particularly post-surgery, vitamin deficiencies such as B12 or folate, vascular neuropathies, bilateral stroke, and diabetic or other peripheral neuropathies. A sensory motor reflex or SMR examination of the upper and lower limbs will aid in confirming the GBS diagnosis. Spinal cord syndromes, myelopathies, and radiculopathies will follow a dermatomal or myotomal pattern. On the other hand, the sensory and motor deficits characteristic of GBS will cross the dermatomal and myotomal distributions and may not follow a distinct pattern at all. Assessment of the cranial nerves will differentiate further between GBS and other conditions, such as vitamin deficiencies, vascular, diabetic, or peripheral neuropathies, and stroke. Cranial nerves 3 to 7 and 9 to 12 will often be affected by GBS and can be recognised as a cluster. The first diagnosing procedure is the SMR exam. I will first conduct the sensory component. George, please close your eyes and place your hands out in front of you. This is sharp and this is soft. I want you to tell me which one you feel when you feel it.
Sharp, 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 soft, soft, sharp, 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 soft, 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 sharp, soft, sharp, sharp, soft, soft, sharp, soft, sharp, sharp, soft, sharp.
That concludes the sensory component. Now onto the motor examination. In a clinical setting, the myotomes would be tested bilaterally. For the purpose of this video, I will be testing them unilaterally. For C5, I'll ask the patient to flex their arm like this, resist my force at the elbow. For C6, resist my force. For C7, resist. C8, cup your fingers like this, resist. T1, spread your fingers and resist. For L1 and L2, I'll get the patient to flex their hip and resist my downwards force. For L3, resist. L4, resist dorsiflexion. L5, resist plantar flexion. And S1, resist knee flexion. That is the conclusion of the myotome test. Next are the reflexes. The reflexes component of the SMR exam will also be performed unilaterally for the purpose of this video. So for C7 is the triceps reflex, get the patient to fully relax. C5, C6 can be the brachioradialis or the biceps reflex here. Okay. L3 is the patella reflex. S1 is the Achilles reflex. And L4 is the medial hamstring reflex. That concludes the SMR exam. Next up are the cranial nerve exams. Cranial nerve 1 is assessed by asking the patient if they have noticed any changes in their ability to smell. If they have, perform a smell test. And now I will assess cranial nerve 2, the optic nerve. First, I assess the general position and symmetry of the eyes and eyelids and the size and symmetry of the pupils. Now I will perform the pupillary light reflex on both of the eyes, as well as the accommodation reflex on both of the eyes. Okay, and now I will test the patient's visual acuity by reading the 20/20 line on the Snellen chart behind me.
LEFODPCT.
Thank you. And I'll get you to read the first line that you see at an arm's length.
The median nerve passes through the two heads of the pronator teres.
That's great, thank you. That tests the visual acuity. Now I will use my neurological pins to assess the patient's visual fields. Please cover one of your eyes. I'll cover the same eye. And I want you to tell me what colour pin you see coming into your field of vision when you see it.
Red. Red. White. White.
I would also perform this test while covering the other eye. Now to move on to cranial nerve 3. Cranial nerves 3, 4 and 6 are tested together. First, I will assess the patient for any latent squint by performing the cover test. I will test the patient's eye pursuit by performing an H. Please follow my finger without moving your head. Okay, and now to test the patient's saccadic eye movements. Please follow my finger without moving your head. Okay, now I will test the patient's convergence. Focus on my finger. That concludes the test for cranial nerves 3, 4 and 6. Now to assess cranial nerve 5, the trigeminal nerve. First, I observe for any muscle wasting. There isn't any, so now I will test the muscle power. Clench your teeth, temporalis, relax. Clench your teeth, masseter, relax. And for buccinator, I'll get you to blow your cheeks full of air, and don't let me push your air out. That's great. Now please tell me if you feel my pressure on both sides of your face equally.
Yes. Yes. Yes.
And that concludes the test for cranial nerve 5. To test cranial nerve 7, the facial nerve, I first observe the facial symmetry of the patient, and then I ask them to perform a few simple facial expressions. I'm testing for their ability and also symmetry in these expressions. Please raise your eyebrows. Yep. And now squeeze your eyes tight. Perfect. Show your teeth. and whistle. That concludes the exam for cranial nerve 7. Now I will assess cranial nerve 8, the vestibulocochlear nerve. First, I assess the patient's gross hearing. Do you hear these equally in both ears?
Yes.
Then I will perform the Renee's test. Do you hear this?
Yes.
Tell me when it stops.
Now?
And do you hear this?
Yes.
Okay. Now to perform the Weber's test. Do you hear this equally in both ears?
Yes.
Those tests test sound conduction through the ears. Now I will test balance and walking. And now to assess the balance component of the vestibulocochlear nerve. I will first ask the patient to walk on their toes. That's great. And then turn around and walk on your heels. And now I will perform the head impulse test. Please take a seat. I'll ask the patient to fixate on a point on my face. I'll ask them to focus on my nose while I quickly turn their head. Please focus on my nose. This concludes the examination for the vestibulocochlear nerve. Cranial nerves 9, 10 and 12 are tested together. First, I'll ask the patient to stick their tongue out and move it from side to side. Wonderful. Now I'll get you to stick your tongue inside your cheek, resist against my pressure. On the other side, resist against my pressure. Now I'll ask the patient to stick your tongue out. Say ah.
Ah.
I'm looking for the soft palate to rise and not to deviate to one side. I would also test the gag reflex, but I'm not going to do that for the purpose of this video. Next, I'll ask the patient to cough. And this tests the larynx. The final cranial nerve to be assessed is cranial nerve 11, the accessory nerve. I'll ask the patient to shrug their shoulders and keep them up. Resist my pressure. Now turn your head to one side. Resist my pressure. And the other side. Resist my pressure. This tests the integrity of the accessory nerve. The chiropractor can be confident in the diagnosis of GBS once the syndrome's characteristic deficits are elicited through the patient's history, SMR, and cranial nerve examinations. This concludes the presentation on Guillain-Barré syndrome.